All right, everybody. Welcome to the Orthopaedics 2 session at this year's virtual ASB. My name is Jessica Goetz. I am at the University of Iowa, and I'll be moderating this session along with my co-moderators, who I'll let introduce themselves.
Hi, I'm Jen Nichols. I'm an assistant professor at University of Florida.
And I'm Josh Baxter. I'm a research assistant professor at the University of Pennsylvania.
So we have a wide variety of topics today, spanning from the spine all the way to the extremities. So I encourage you to, as you have been for the past couple of days, type your questions into the chat box. We'll be reading those after each block of 4 presentations. We have an extra talk, bonus orthopedic talk in our session this morning. So we will have 5 talks in our last block of talks, and we will be able to keep this link open in order so that we don't have to cut any of the discussion short. And as previously, once we move on, everything's going to move over to Slack to continue our discussions. So our first talk this morning is going to be given by Elizabeth Bjornsen. It's titled Increased Cervical Spine Musculotendon Strain with Enlarged External Occipital Protuberances.
All right, thank you for the introduction. Today I'm going to share some exploratory research as I was introduced here, looking at increased cervical spine musculotendon strain with enlarged external occipital protuberances in young adults. In 2019, 81% of all Americans were estimated to own a smartphone, and that statistic increased to 96% when surveying young adults alone. While there are a lot of different postures associated with device use, it is most commonly associated with neck flexion. And then in the media, there has been awareness drawn to the presence of bone spurs in cervical spines of young adults. You can see an example of what that bone spur would look like on the right, circled in red. And really, there's just a lot unknown about what it means to have these bone spurs in the cervical spine and how it could impact function. And so that inspired the project going forward, and it leads into the purpose, which is to compare cervical flexion, range of motion, and normalized cervical extensor musculotendon length between those with and without an enlarged external occipital protuberance. And for brevity's sake going forward, I'll just refer to these as EEOPs. Participants were split into 2 groups, those with an EEOP and those without, as defined by previous protocols. And then cervical x-rays were taken in both the neutral and fully flexed position. And those x-rays provided individualized landmarks to create a mechanical model using OpenSim software, where we computed normalized cervical extensor musculotendon strain measures for 7 different muscle segments. We also looked at cervical flexion range of motion, and that was calculated with image J. And then between group comparisons were conducted with t-test with a Bonferroni correction to account for multiple comparisons as well, and then Hedges G sizes were also calculated. Here's an example of what the cervical x-ray would look like in that neutral position. You see the layover with the individualized landmarks that were used to create the model, and then on the right you would see that same position and how it would look in that computerized model. And the same thing here, you're seeing the fully flexed position both on the cervical x-ray and then on the computerized model as well. Here we're looking at musculotendon segment lengths. On the left, you have all the different segment names. This is not exhaustive, but it is something that we're showing here on the slide for brevity's sake. And they're split out by those with an EOP and those without. Those with an EOP across all segments had higher values of the segment lengths in comparison to those without an EOP. Then there were no overlaps in standard deviation as well. Those boxes in red represent significant differences between groups. And those that were significant were accompanied by very high effect sizes, most approaching 2. And the other thing I'll point out here is that of the multifidus muscle, 4 out of its 6 segments were determined to be significant. We also looked at cervical flexion range of motion. There were no differences between groups here. So what does this all mean? Well, EOP presence was observed in 41% of our young adult sample, and this is on par with what we've seen in previous literature. We also saw that range of motion was not significantly different between groups, so it appears that function was not compromised. We also looked at the affected musculotendon segments, and all of those had insertion points on the C2 vertebra. Again, the multifidus muscle, 4 out of its 6 segments were significant, and it makes sense. It's a muscle that prevents forward neck motion, and it's a stabilizer muscle. But again, this is exploratory research. There were things and limitations that accompanied this study, one being that we did not standardize the position of the neutral posture, and then we did not include thoracic data as well. So it really opens up a lot for future directions within this area, one being longitudinal studies following people across the lifespan, as well as incorporating some patient-reported outcomes to determine more clinical relevance in this population. So thank you all for listening, and I'll take your questions at the end of the block, and feel free to email me as well if you have any questions.
Thanks, Elizabeth. So our next talk will be given to us by Julian Acasio, and he'll be talking about trunk-pelvic coordination during unstable sitting at varying task demand.
All right, thanks for the introduction. Hopefully everyone can hear me okay. Jessica said I'll be presenting on trunk-pelvic coordination during unstable sitting at varying task demands. I want to give a quick shout out to my co-authors, Maureen Nussbaum and Brad Hendershot. So unstable sitting is commonly used to assess trunk postural control in isolation, as it can eliminate the influences of the upper and lower extremities. Traditionally, it's quantified using measures derived from the center of pressure, and these are great at quantifying overall task performance. They don't tell us a whole lot about the underlying movement strategies used to maintain trunk postural control, which can be important in identifying risk factors for injury. So in this study, we proposed using vector coding techniques to quantify trunk pelvic coordination during unstable sitting at varying task demands. Vector coding is a way of quantifying how two segments move relative to one another based on their coupling angle, and it's previously been used in this manner in tasks like walking, turning, and lifting. We hypothesized that as the instability level increased, we would see a corresponding increase in anti-phase movement and a decrease in in-phase movement. We had 13 uninjured participants in this study, and each of them sat on the wobble chair at 4 different instability levels. The wobble chair is displayed seen here, has a flat seat surface that rests on top of a ball and socket joint. It has 4 springs around it. We can adjust the distance of these springs to the central pivot point. Sorry, there's a cat attached to my laptop at the moment. And we can therefore control how unstable the seat is. We base the 4 instability levels off of each individual's gravitational gradient, which is essentially a measure of mass distribution. So at the 100% condition, 100% of the forces due to gravity were counteracted by the springs. At the 75% condition, 75% of the forces and moments were accounted for, and so on. Therefore, as the percent of the gravitational gradient decreased, instability would increase. While they were sitting on this chair, we tracked the trunk and pelvis motion using optimal motion capture and used that to determine coupling angles, which were then binned into one of 4 phases. Anti-phase, when the trunk and pelvis moved in opposite directions. In phase, when the 2 segments moved as one or in tandem. And trunk and pelvic phase, which is when only the specific segment was moving. We assessed mean effects using signal factor ANOVAs and pairwise effects using t-tests. So here's just a quick summary of our results. On the y-axis here, you have phase frequency in terms of percent of the trial, and the various instability levels down the bottom. These black arrows are indicating the main effects we found, and the direction is the corresponding trend. So in the sagittal plane, we saw increases in anti-phase movement and a decrease in in-phase movement. Similarly, in the frontal plane, we saw an increase in anti-phase movement, and while it wasn't statistically significant, we did tend to see decreases in in-phase movement as well. And here in the transverse plane, we had increases in both in-phase and pelvic phase movement, while trunk phase movement decreased as instability increased. So these were largely in support of hypothesis, particularly in the sagittal and frontal planes. Moreover, at the lower instability levels, the larger in-phase moment or motion we observed suggests a possible stiffening strategy. So that is, the trunk and pelvis moved essentially as one segment, likely to limit any extraneous movement that might cause a loss of balance. At the higher instability levels, however, this likely became too difficult. So we noticed participants switched to a more counterweight strategy that involved more anti-phase movement. What likely happened is whenever the pelvis moved, the trunk would move in the opposite direction in order to offset each one's gravitational effects and limit any excessive leaning in one direction. In terms of big picture implications, I think these results, sorry, had it stack me again, successfully discriminated between levels of instability during unstable sitting, and therefore can be used to quantify the underlying movement strategies of trunk postural control. In the future, this data can serve as a baseline for studies investigating individuals that have impaired trunk postural control, so people like individuals with lower limb loss or low back pain. I just want to end by thanking the rehab research team over at Walter Reed, as well as all of our funding sources. Thank you.
Thank you, Julian. Just a reminder, type all your questions to our speakers in the chat box, and we'll be talking about all the questions after our next two talks. So next up, we will be hearing a presentation from Tara Diesbourg. We'll be talking about the impact of sitting on active trunk stiffness and the mitigating effect of age.
Okay. Thank you for the introduction. So like she said, I'm going to be talking about this concept that's known as active stiffness, how it changes with age, and then what these changes might mean for us. Active stiffness, as it's used in spine material properties research, is essentially spine stability. So both terms describe the spine's ability to return to its neutral starting position following a perturbation, while passive stiffness would look at the passive elasticity of the inactive trunk tissues. Active stiffness depends on the muscles' contraction as they respond to a perturbation as quickly as possible. Sorry, there's a video. There we go. So to measure active stiffness in this study, we used a custom-built apparatus which placed the participant in an upright, semi-seated position. 15% of their body weight was suspended from the front and back of a harness at the approximate height of their center of mass. At a random time, the weight suspended from the back of the harness was dropped, leaving the suspended weight in the front to pull the participant forward. The participant was instructed to sit as relaxed as possible prior to the perturbation and then return to neutral as quickly as they could after feeling the tug. So the variables of interest for this study included the time that it took the individual to stop their forward motions and the linear displacement of their center of mass. So that went really quickly. I'll slow it down here so that you can see what we measured. But in reality, on average, the entire response took less than half a second from the onset of the perturbation to the participant returning to their neutral position. So increased active stiffness would be represented by a faster response or a decrease in the center of mass displacement and time. The variables were measured both before and after we had the participants sit at a computer for 60 minutes. Now for the results. So first, orient you to some recurring formatting that you'll see as we move through these data sets. Center mass displacement and time will always be on the y-axis, and this coloring system will translate to all of our other graphs as well, where black is always going to be the data before sitting, and gold is always going to be the data after sitting. Paired samples t-tests revealed a significant decrease in both displacement and time after sitting when we don't control for age. This means that after sitting, an individual's ability to respond to a perturbation, or their active stiffness, if you will, increases compared to that measured before sitting. And now we have age on the x-axis, and you can clearly see the three age groups that we recruited here. When looking at the between group differences, a one-way ANOVA with a Bonferroni post-hoc adjustment revealed that after sitting, the younger group displaced significantly less than the middle-aged and older groups. And in terms of response time after sitting, the younger group was shown to respond faster than the middle-aged group. So these last two graphs both point at an increase in active stiffness in the youngest age group. So why exactly do we care about all of this? Well, previous research has shown that when you sit, the curvature of the lumbar spine essentially inverts, so that rather than a concave curve in the low back, we see a flattened convex curve. This means that all of the muscles, ligaments, and tendons of the spine are stretched and held in this lengthened position until the person stands back up again. And knowing what we know about the viscoelastic properties of human tissues, specifically the creep, hysteresis, and load relaxation responses, we know that the tissues might take some time to revert to their normal resting lengths, potentially leaving the spine at an increased risk for injury due to a decrease in spine stability. Fortunately, given what we found in this analysis, this doesn't appear to be the case. In fact, spine stability appears to increase after sitting in the younger participants. This could be a protective mechanism of the spine to prevent injury when individual tissue stiffnesses may be compromised. The problem is this protective mechanism appears to be reduced with age, where older workers didn't show the same increase in active stiffness as their younger counterparts. So this could leave older workers at an increased risk for injury should they be required to lift and/or bend after sitting for a prolonged period of time. But further investigation is needed to determine the exact mechanisms involved and whether age-specific ergonomic recommendations should be made. Thank you so much for your time and attention. If you'd like to discuss this further, if you want to talk about other directions we're taking this research, don't hesitate to reach out at the contact information on the slide. So I look forward to your questions following this block of presentations.
Thanks very much, Tara. So our final talk of this first block will be given by Alexa Johnson, who will be talking about connecting the pieces, how our low back pain, let's try that one more time. Connecting the pieces, how low back pain alters lower extremity mechanics in active individuals. Sorry for your title mess up, Allie.
It's okay.
Take it away.
All right, so like I said, I'm Alexa, here to talk to you about how lower extremity mechanics change in individuals with low back pain. So research has indicated that 37% of athletes suffer from low back pain in any given season. And while experiencing low back pain is typically a non-traumatic injury, knowing that 1/3 of athletes' seasons may be inhibited due to this injury is surprising given the lack of information that surrounds an athletic low back pain population. Research in low back pain populations has indicated that during walking, individuals with low back pain have increased frontal plane knee movement at ground contact, and during running, they tend to have increased knee stiffness. While the majority of research focuses on an older low back pain population, there seems to be a lack of information on how biomechanics change for higher impact tasks that are common for more active low back pain populations, like athletes, the military, and even weekend warriors. So the purpose of this study was to evaluate patient-reported outcomes and lower extremity landing mechanics in active individuals who suffer from chronic low back pain, to kind of make that connection from mechanical changes to clinical presentations. We recruited 28 individuals with chronic low back pain, defined by experiencing pain for greater than 4 months, and had to at least score a minimum of a 5 on the Tegner Physical Activity Scale to identify as active. And we had 28 matched controls in terms of age, sex, weight, and activity level. Everybody completed a knee osteoarthritis outcome score, which is also known as the KOOS. It's a patient-reported outcome that quantifies knee function in 5 different areas of life, including symptoms, pain, activities of daily living, quality of life, and sport and recreation. And Standard did a 3D motion capture of 3 different functional tasks: a single limb hop, a drop vertical jump, and a crossover hop. What you see here is the crossover hop. For this project, we focused on the knee. So we collected sagittal and frontal plane knee kinematics and kinetics, as well as peak vertical ground reaction forces during all of the functional tasks. We use an independent t-test to assess differences between the control group and the low back pain group in those KOOS scores. You can see that the low back pain group is that navy blue and the control group is the gray. We found that the low back pain group consistently reported worse self-perceived knee function in 4 of the 5 sections, including symptoms, pain, activities of daily life, and quality of life. While the low back pain group is still barely in the healthy range, according to the KOOS scores, there's a noticeable decrease from the healthy control group that is definitely while this is a younger population, we know that as they get older, it's possible that this difference gets more and more exacerbated. We used repeated measures ANOVA and post-hoc t-tests to assess our group by limb differences. We found that all 3 functional tasks, there were no differences between the low back pain and the control group, but the low back pain group consistently experienced asymmetrical frontal plane knee movements, reporting greater knee valgus angles during landing on the non-dominant limb compared to the dominant limb. These mechanical asymmetries may be compensations from the low back pain that may put them at an increase for subsequent knee injuries. So to kind of circle back around, on the active individuals with low back pain present with worse self-perceived knee function compared to healthy controls and have increased frontal plane knee movement similar to some previous research. Ultimately, clinicians may benefit from assessing self-perceived knee function in individuals with low back pain to avoid potential future injury risks or musculoskeletal diseases, as it may just be something to look out for future biomechanical changes coming. And I just want to acknowledge my funding sources and everybody who helped me complete this project and take questions on Slack. You can find me on Twitter.
Thank you. And thanks to our first set of speakers. So similar to other sessions you've been in, we're now going to do questions for those first 4 speakers. Please keep typing your questions, especially those for our last speaker, into the chat. We're going to do kind of a round robin so that everybody has an opportunity to answer some questions relative to their talk. So starting with a question for Elizabeth. This comes from Nathan Shalady. I apologize if I butcher any of these names. Thank you for your presentation. Aside from cervical x-rays, did you also measure range of motion with a goniometer or see range of motion device?
Yeah, absolutely. Great question. We did not use a CROM device for this study. We measured range of motion on image J using individualized landmarks. So range of motion was calculated from C7 to C1 to the campus.
Thank you. Our next question will be for Julian. Julian, this question comes from Erica Nelson Wong. Nice study. In our work in a similar unstable sitting device, we found a very large learning effect. What familiarization protocol did you use, if any, and what instructions were participants given? Were they asked to maintain balance, or did you ask them to perform movements in each of these planes?
Yeah, so we gave participants 3 practice trials at each of the instability levels before the test trial was recorded. And as far as instructions were given, they were simply asked to maintain balance without slouching.
Thank you. Our next question is for Tara. I'm going to take the question from Gretchen Roman. Thanks for an interesting talk. What are your thoughts about compensatory strategies by your lower extremities in response to perturbation, particularly through the knee platform?
Yeah, thanks for the question. So just watching the videos and seeing the way they responded, I think they were definitely transmitting some of the forces through their knees on the kneeling platform. There was a belt around their waist or around their hips to kind of stabilize the pelvis and hopefully isolate too much motor or muscle contribution from below the pelvis. So I'm hoping that took that into account, but there was obviously some knee movement. So in the future, I do want to look at EMG in the legs. For this study, I didn't put EMG any lower than that, but than the pelvis. So I think isolating the pelvis should have isolated the back musculature, but I would need to check to make sure.
Thank you. Our next question is for Alexa. It comes from Caitlin Gallagher and apparently Madeline Grosclos. I'm sorry about my pronunciation. Had a similar question. So great talk and study. If I understand, you said low back issues may lead to knee injury, but do you think it could happen the other way around, knee issues creating low back dysfunction?
Absolutely. So I think this is kind of a chicken or the egg situation, and we've definitely found it both ways that there are some people with low back pain who may have increased risk for a lower extremity injury, but also that a lower extremity injury may lead to low back pain, depend on the compensations. So I can say when we were recruiting individuals, nobody that we included in this study in either group really had any lower extremity injuries or surgeries. But there are definitely a large group, I would say probably, maybe, I don't know how many number wise, but there was a large group that was excluded because they did have a previous lower extremity injury or surgery. So it's definitely something that we've seen kind of go both ways.
Great. Another question for Elizabeth. So I thought it was interesting that you wanted to expand your analyses to other spine segments. Can you talk a little bit about what compensations you expect to see when you look outside the cervical region?
Absolutely. So for the study, we just looked at the cervical spine. And so anything that's happening in the thoracic or lumbar region, we just don't have data for. So that's something that we can look at in the future.
Okay. Julian, another question for you. It comes from Jessica. What did the participants do with their arms? How did you have them control or not control their arm movement?
Yes, we had them cross their arms across their chest. That way they could use it to help in balance.
Thank you. Another question for Tara. Did you measure or notice slouching behaviors during sitting? Also, do you think the short-term motor control adaptation to a sitting posture may have contributed to a faster response or shorter perturbation?
So definitely while sitting at the computer for an hour, people were slouching. I measured that. I didn't present it in this presentation just for time's sake. I do think there could be some sort of motor control contribution to the response, but they were sitting for a long time before going back into the stiffness device. So I don't know whether the effects would be that pronounced. They were sitting before the test originally as well. So I think that's kind of controlled for, but I didn't constrain their sitting when they were sitting at the computer. So there was definitely some slouching. There was actually no backrest so that we could track their spine posture. So I definitely looked at that, and there was not some great back postures in the sitting. So that could also have an effect.
Yeah, so as a follow-up, you have a question kind of later about that backrest you just mentioned. So can you expand a little bit on whether or not the backrest would have given different results compared to the knee platform?
Yeah, so there was a short backrest on the device that kind of helped isolate the pelvis out of the equation. So the belt against that lower kind of pelvis rest was how I secured the lower limbs. This apparatus actually works forward and backward. So I couldn't really have a backrest on their back as well as having all of the markers along their spine. So it would have obscured any kind of motion capture that I could do. But the weight in the front was also dropped, pulling them backwards. So I had to make sure that there was nothing to interfere with that, and I didn't want anybody to get hurt. So
yeah. So our last question for this session is going to be to Alexa, and Alexa, I'm going to combine a couple on you. Okay. So you have a couple of questions asking kind of about the participants. So can you expand a little bit more on whether or not they were elite athletes or active in the same way because your tasks looked kind of challenging? And then also, do you have plans in the future to look kind of at other joints like the hip and ankle?
Yeah, so a 5 on the Tegner physical activity scale is heavy labor in terms of work, but those weren't really any of our participants. So this is the minimum, but also recreational jogging and some competitive sports that are low contact, like cycling and cross-country skiing. I will say our average score for physical activity was probably a 6 or a 7. Which is more competitive and recreational sports that are played more than 3 times a week. We definitely did have some elite college athletes, some D1 athletes. We had some active duty military individuals, and we also had people that were played for like their club rugby team, recreational, things like that. So it kind of spanned across them, but everybody was able to complete the task. And they all had been semi-familiar with it. So if you're unfamiliar with ACL research, it's a common task that's used in ACL return to play, known as functional tasks for them. We definitely do have some interest in looking at the other joints up and down the kinetic chain, looking at the hip and the ankle. So that is forthcoming.
Great. So thank you to this first round of speakers. Realize you can continue talking to them and interacting with them on the Slack channel. And I'm going to turn it over to Josh to introduce our next speakers.
Great, thanks, Jen. So I'm happy to introduce our next speaker as Mac Preibel from the University of Texas at Austin, who's going to tell us why thoracolumbar and pelvic kinematics are associated with paretic force production. Take it away, Mac.
All right. Well, thank you for the introduction. My name is Mac Preibel. Let me see if I'm sharing the screen now. Yes, so I'm a PhD student at UT in Austin in the Neurorehabilitation and Biomechanics Lab, led by my advisor, Dr. Haoyuan Shao. And I think that it's important to examine these relationships between trunk movements and paretic force production because there is more to hemiparesis than just peripheral limb weakness. You have impairments in strength multidirectionally and bilaterally. There are delayed reaction times. There are impaired postural adjustments. And in observing people walk, there are some typical deviations from normal trunk movements. So you tend to have more mediolateral sway. There will be decreased counter rotation and increased movement in the sagittal plane. This is all discussed in an excellent review by Van Krinkage et al. And one of their final takeaways is, importantly, studies suggested that more natural trunk movements were observed when walking speed was increased. And so this was kind of the starting point of asking this question: do the altered trunk kinematics predict the decreased paretic propulsion of slower walking? So we looked at peak paretic propulsion because it correlates well with self-selected gait speed, and improvements in self-selected gait speed following a course of rehabilitation are generally met with a commensurate improvement in the peak paretic force production. It also helps us to distinguish between non-paretic compensatory adjustments. So this is really kind of trying to track and understand a movement toward healthier, more balanced walking. This was a secondary analysis of a previously collected data set involving 24 subjects who were at least 6 months post-stroke who were able to walk without an assistive device. They walked at their self-selected gait speed on an instrumented split belt treadmill. And we looked at the pelvis relative to the lab and then the thorax relative to the pelvis in order to predict peak paretic propulsion. To track the changes, we looked at movement across 2 time periods during single limb support. There was the initial moment as the body shifts into paretic single limb support into mid stance, and then from mid stance into initial contact of the non-paretic swing limb. So this ends up yielding 2 different time periods, looking at the trunk and the pelvis, and in 3 planes of movement, which ends up being a lot of variables. The intention of this study is just to help refine our focus and develop a preliminary understanding of what may be important. So we use stepwise linear regression in order to reduce this to a feature set that is going to be a bit more salient. The trunk looms large in the first half of single limb support, and then the pelvis becomes larger in the second half, and altogether the final model accounts for 69% of the variance. These are the standardized beta coefficients, which can give you a sense of the relative impact of these changes. So it's unsurprising to me that the pelvis is a large component of this, thinking about how prominent hip drop is during single limb support. But the relative contribution of the trunk does seem notable. Fortunately, the interpretation of the direction of these coefficients is aided by the fact that it is just what the trunk normally does during walking. So in the frontal plane, it is consistent with shifting the hips over, which would be the same idea that you're not tilting in order to shift the weight. And in the transverse plane, it is the counter rotation of the thorax relative to the pelvis and the direction of that swinging limb. So leads to some key takeaways. It helps to support these previous observations that increased speed is associated with more normal trunk movement. It helps to establish a clearer link between those normal trunk movements and the actual paretic kinetics. And it can help to refine our focus to build more involved biomechanical models, particularly emphasizing that transition into mid stance and in particular the frontal and transverse planes. So thank you for your time and to our funding sources, and look forward to your questions at the end.
Great, thanks so much. I'd like to introduce our next speaker out of the University, Washington University in St. Louis, is Ki Song Zija, that alter dynamic flexor and abductor muscle moment arms and lines of action.
All right, can everybody see my screen? All right. Thank everybody. And if you stuck around at the end of the 3-minute thesis presentation on Wednesday, you might remember me talking about my dissertation research. It's about holding people's hips on lab computers. But in case you still wonder what that means, you are in the right place today, because I'm going to give a more specific talk on modeling hip dysplasia mechanics, more specifically the effect of periacetabular osteotomy, which is a common surgery for hip dysplasia, on its effect on hip muscle moment arms and lines of action during dynamic activities such as walking. And we have nothing to disclose for this study. And so hip dysplasia is known as abnormal bony anatomy of the hips, such as a shallow acetabulum that cannot fully contain the femoral head. The patient frequently suffers from labral tears and early arthritis. And recent mechanical study also estimated elevated joint loading compared to controls, especially medially directed hip joint reaction forces, which could be related to the risk for injury. And to manage the injury risk and reduce excessive loading, the PAO surgery alters the shallow acetabulum by rotating it to better cover the femoral head. However, the clinical outcomes for PAO is varied, as some patients continue to suffer from injury, and the rate towards OA did not slow down. To improve the clinical efficacy, we need to better understand how anatomy and mechanics are related in dysplasia. And one key factor could be the hip muscles, as it generates significant forces inside the joint. More specifically, the moment arm length and the lines of action respectively determine the muscle's ability to generate force, then contribute force towards different parts of the joint. However, those quantities are rarely analyzed in hip dysplasia, as only one study reported the reduced moment arms in gluteus medius compared to controls. And really no study investigated the effect of surgery on hip muscle moment arms, lines of action, or mechanical contributions. So that's what we did to compare those quantities during gait before and after surgery. And we did that by using subject-specific musculoskeletal models that combined motion capture and 3D MR data, which we build shape models. So those MR-based OpenSim models has subject-specific hip joint center locations, and also muscle origins and insertions informed by the 3D geometry. Each subject has a pre and post-op data. There's 5 subjects, obviously there's preliminary work. And the post model has updated hip joint center location and the rectus femoris origin, both of which could be directly affected by the surgery. And from each pre and post model, we estimated the joint reaction force by static optimization. As you can see an example, it peaks twice over the gait cycle, and the time point for the 2 force peaks are where the quantities are statistically compared. Also compared are the dynamic hip muscle moment arms and the lines of action, meaning they are true to the hip joint positions during gait. As for the results compared to pre-surgery, after PAO, there's a decrease in both the resultant and the medial joint reaction forces. And simultaneously, the abduction moment arms for gluteus medius and rectus femoris increased. And then there's a decrease in the medial lines of action for gluteus maximus and medius muscles. So the reduced overall loading for PA may suggest the effectiveness of PAO. And this could have been achieved by medializing the hip joint center, which directly increased the abduction moment arms for gluteus medius, meaning the muscle will now need to generate less forces to stabilize the hip during gait. As directly affected by the surgery, the rectus femoris had a momentum change in both flexion and abduction, which could have contributed to the mechanical changes in the joint as well. And lastly, the decreased line of action from gluteal muscles, meaning those muscle forces contributes less to the medial direction, which could have also helped reduce medial loading. It's our hope that as these results develop, we can use them to guide future PAO surgical planning in order to best reduce excessive loading and improve clinical outcome. And with that, I would like to thank my co-authors, Dr. Closey, Molly Shepard, and my advisor, Dr. Harris. Thank you.
Great, thanks so much. Perfect timing. So our next presenter is Emily Levy from the University of Texas at Dallas, who's going to be talking about the kinematic and kinetic comparison of multiple hip pathologies during sloped and level walking. So take it away, Emily.
Thank you. Just a minute. Sorry, I think I have too many windows open. It didn't have this issue earlier. I apologize. Hi, I'm Emily Levy, a PhD candidate from UT Dallas, presenting, as he said, about hip biomechanics. We work with doctors at UT Southwestern Medical Center in Dallas. Oh my gosh, I don't have it on. I'm so sorry. OA, which affects 4% of Americans over 50, is a progressive disease. It's vital to catch it early, as we're looking at two of the most common causes of osteoarthritis, dysplasia and impingement, often presented in young people, especially athletes with hip pain. These developmental deformities are anatomical deformities to the hip and femur. Dysplasia typically has a shallow acetabulum, causing instability and dislocation, while impinging hips may present as overcoverage of the acetabulum or a bumpy femoral head, causing articular interference. In addition to leading to premature osteoarthritis, these pathologies can cause comorbidities that lead to movement modifications, but previous research lacks in quantitative comparisons between the two, assessing it across different terrains and within strides, not just peaks. We assess patients before undergoing hip preservation surgery. We assess them during 1-minute self-selected speed trials on decline, incline, and level walking on a treadmill, and we track their kinetic and kinematic data. We analyze sagittal hip biomechanics across subject strides using t-tests with statistical parametric mapping. Here are the groups: 17 dysplastic, 13 impinged, and 9 controls. They were diagnosed by Dr. Wells at UT Southwestern using standard radiographic angle measurements, as well as history and so these are the results. First, we'll be looking at ground reaction force. So this is across 0 to 100% of stance. The bottom row is these regions of statistical significance using statistical parametric mapping. So those are have a statistical significance using alpha equals 0.05. So we saw reduced braking and propulsion in both DDH and impinged patients, but there were longer regions in dysplastic patients and the longest in decline, whereas FAI had shorter regions but longer in incline. Also, we looked at joint angles. So this is a hips flexion angle. We saw reduced hip extension in both dysplasia and FAI, but in FAI we only saw it in an incline. In dysplasia, they were longer in the longer regions in decline and incline. And then finally, we looked at joint moments. So we saw reduced extension moments in dysplastic patients in initial stance, but we saw reduced hip flexion moment in FAI during pre-swing. But we did not see that in the decline. It was only level and incline. And then hopefully you guys can see the speeds. I can't because your pictures are blocking, but they did have significantly slower speeds in the dysplastic and impinged patients. So in summary, each group showed regions of significant difference, but they were, dysplastics had more widespread regions, whereas impinged had more specific regions. The dysplastic region, dysplastic patients showed differences in early stance that suggested protective muscle activation to stop working to stop extension, whereas FAI applied their guarded muscle activation during early stance to stop extension. FAI was more I have this backwards. I apologize. FAI saw more incline adaptations, whereas dysplastic saw adaptations were exacerbated in both incline and decline. So hopefully these can help with different therapeutic and surgical treatments, like activity modifications, regional muscle strength training, an array of hip preservation surgeries. Thank you. If you have any questions, here's my email address, and I'll also answer questions after the block.
Thank you. And we will move along to Mike Saman from the University of Kentucky, who's going to talk about hip joint muscle and contact forces during sit to stand and stand to sit tasks in patients with FAI.
All right. Thank you, Josh. Sorry, I'm trying to share this. All right, cool. Can you guys see my screen?
Yes, we can.
All right. Thanks, Josh, for the introduction. My name is Mike Saman. I'm an assistant professor at the University of Kentucky, and I'm going to be talking to you today about some of our preliminary work looking at hip joint muscle and contact forces during the sit to stand and stand to sit tasks in patients with Femoroacetabular impingement syndrome. So FAIS consists of abnormal hip joint morphology. These patients also exhibit early onset of cartilage damage or degeneration, as well as severe hip pain. Previous work has shown that patients with FAIS exhibit weak hip extensors, which can lead to higher anterior hip joint contact forces, as shown by some previous modeling work, as well as, it might incite the larger hip joint demands that we see during the sit to stand task. And so the purpose of our study was to assess hip joint strength, muscle and contact force patterns of the hip joint during the sit to stand and stand to sit tasks in patients with FAIS, as well as asymptomatic controls. And so we hypothesized that compared to the asymptomatic controls, the patient group would exhibit weaker hip extensors, lower hip extensor muscle force production, as well as higher anterior hip joint contact forces during these tasks. So for this study, we recruited and tested 6 pre-surgical female patients with FAIS. And then we also tested 5 females that were age and BMI matched asymptomatic controls. So our control group did not have any clinical signs of impingement or any signs of radiographic osteoarthritis. So all of our patients and controls obtained an anterior posterior pelvic radiograph to assess radiographic hip OA. Everyone underwent a 3D gait analysis of the sit to stand and stand to sit tasks at a self-selected speed. And then we used these data in OpenSim and utilized the deep hip flexion model to estimate muscle forces and hip joint contact forces using static optimization and joint reaction analysis, respectively. All of our study participants also underwent isokinetic strength testing of the hip flexors, extensors, adductors, and abductors at 60 degrees per second. Our dependent variables were peak hip strength, peak muscle force, hip muscle forces, peak hip joint, anterior, superior, medial hip joint contact forces. And then we kind of dove a little bit deeper and we looked at the angular orientation of the hip joint contact force vector, as well as the distribution of the contact force vector to give us somewhat of a surrogate measure of potential contact area. And then our statistical analysis, we compared between group differences using independent t-tests, as well as we looked at the differences between both tasks within the groups, and we did this using a paired t-test. So contrary to what we thought would happen or what we would find, our patient group exhibited weaker hip abductors compared to the asymptomatic controls. But interestingly, we didn't find any between group differences in our hip muscle force production or joint contact force parameters, everything, angular orientation, peak forces, peak contact forces, or distribution in either the sit to stand task or stand to sit tasks as an effective pathology. But when we look at the within group differences, what we found was that within the FAIS patients, these patients exhibited, and these were trends, so they're kind of, just potentially underpowered right now. During the stand to sit task, the FAIS patients exhibited a lower vertical hip joint contact force, so less superior contact force, as well as a trend towards less hip adductor muscle force during the stand to sit task, excuse me. So when we dive a little bit deeper into the contact force parameters, what we see is that the patients, the FAIS group showed a smaller distribution of the hip joint contact force during the stand to sit task as compared to the sit to stand task. We see something similar in the control group, except in the control group, we only see it in the sagittal plane and the axial plane. So basically, during the stand to sit task in both groups, we see what I think, or can kind of start to hypothesize, a more focalized hip joint loading pattern. And so basically summing this up, so within our patient groups, we see weaker hip abductors, which could potentially lead to more adducted hip positions and leave these patients at a higher risk of hip impingement and pain, basically. Also, we can kind of start to see that the stand to sit task may be more sensitive in detecting these hip contact force abnormalities in the FAI's population and even maybe in the control group. So the FAI's patients, basically, our thoughts are that, there's some sort of compensatory mechanism here during the stand to sit task. Lower hip adductor muscle force plus lower superior hip joint contact force in order to potentially reduce pain, which would lead to a smaller joint contact force area in all three planes of motion. But in turn, these patients are potentially focalizing the hip joint loading pattern within the joint and then, leading to more articular cartilage degeneration and potentially more pain in itself. So future work, we could potentially look at some abductor strengthening protocols plus some neuromuscular training to increase hip joint contact forces, the distribution of the contact force, which would hopefully reduce pain and preserve hip joint cartilage health. And so with that, I'd like to thank all of my co-authors, all the grad students that helped out within the Human Performance Lab at UK with the study, as well as our funding sources. Thank you.
Thanks, everybody. So we'll have time for a few questions for this second block of speakers. Let's start with a question for Mac from Josh Baxter. Question was, is this lateral flexion movement driving functional weight bearing and propulsive force, or is it a function of reduced propulsive force?
Yeah, this is a wonderful question, which I think I will be thinking about for a while. I think one interpretation of this is that like the trunk kinematics are a strategy on weight bearing to maybe offload certain, like the lateral hip, so you can still achieve that vertical support. So maybe it's a compensatory reaction there. On the question of whether or not it's driving the propulsive force, you know, I think that it may be a necessary but not sufficient condition. Like if I consider the thought experiment of like, what if you were to create an increased plantar flexor moment at the right time, but you were in this deviated position, would that end up actually creating the direction of force for the whole human structure that you want? And so you know, it may be that that it's not driving it, but it kind of needs to be in that configuration, which I think is an important, ultimately, like, as you know, if someone is in like a, say like a body weight support system, it's like, how are you ever going to figure that out? So yeah, so I think it's necessary but not sufficient.
Thanks. We'll take a question from Jen Nichols for Key. She said, interesting talk. She may have missed it, but what was the magnitude change in moment arm between pre and post-op? And the second question was this change substantially larger than the possible error in muscle location from your MRI segmentations?
Yes, that's a great question. So I didn't put the numbers on my slides, only in the plots. But for gluteus medius at the fourth peaks, the difference, I just looked it up. It's about 45 millimeters, and it's larger for rectus femoris. So for the second question, from another separate study, we found that so really like the sensitivity of the moment arms to like the muscle point placement in the model is not going to be that high, because I would say I'm confident with that. So the effect of uncertainty in the muscle point placement wouldn't affect muscle moment arms up to that point, especially because the muscle moment arms in the modeling standpoint is largely affected by this medializing or lateralized hip joint center location, which directly changes the relative location of the joint to the muscle, and the joint location does plays a significant factor.
Thanks. So a question for Emily. We'll take one from Michael Harris, who says, thanks for your talk. How much do you think the speed differences among groups influence the ground reaction force and moment results?
Yeah, I think obviously, and Cara said it as well, but it is shown that speed can affect these. But it still shows, you know, they had a reduced, they were more protective of their joints during this walking. Post hoc, we've been doing, not post hoc, but we tried to set a fixed speed during the experimentations, where we could also analyze same speed for everyone. Unfortunately, we set it a little too high. I was unaware in the beginning how slow some of the patients would be walking. So like, I think only about 5 or so of like dysplasia patients hit that speed, and less so for impinged patients. So I think going forward, we'll try to get a slower speed to be able to analyze it. But with the patients, at least with that 5 dysplastic, we still saw reduced GRF forces. We just don't have the high number of patients to, I think, to what's the word? Publish it yet.
Okay. And we have time for one quick question from Mike. I'll read the one from Cara Lewis. She said, interesting study. Your sit to stand video showed significant sway back, specifically hip extension, trunk back in the standing position. And was that typical for your participants? And if so, do you think that contributes substantially to your results?
Excuse me, yeah, Cara, that's a really good point. So just thinking through it real quick, we standardized the starting position of all of our study participants. So we have an adjustable stool where we try to have everyone potentially at 90 degrees at the hip, knee, and ankle. And then as they come up, it could be that, you know, they compensate somehow and further extend the trunk back and the hips back in order to, you know, potentially avoid some sort of pain that they feel on a day-to-day basis while they perform that task when they get up from their chair. So it's definitely worthwhile to look at those kinematic changes potentially.
All right, so I have more questions. I'm going to move everything over to Slack, but in order to stay on time, especially since we have this extra talk in our last block, so we'll move on and I'll move the questions over for continuation with the speakers.
Okay, so we're going to move on, and as Jessica just stated, we have a bonus talk, so you get to hear from 5 speakers before the next round of questions, but keep those questions coming in on the chat. So our first speaker in this block will be Cara Lewis. She will be speaking on bone-to-bone distance changes are larger in patients with cam femoroacetabular impingement syndrome.
Thank you. And first, I'd like to acknowledge my co-authors, as well as the team of people that it takes to do this type of research, and of course, the funding. So femoroacetabular impingement syndrome is a motion-related clinical disorder where you have symptoms such as hip or groin pain, combined with clinical signs such as pain with combined hip flexion, adduction, and internal rotation, and imaging findings such as pincer, where there's increased bone on the acetabular side, or cam morphology, where the increased bone is on the femoral side. When we first started looking at this, we thought that both pincer and cam morphology could lead to increased hip OA later. What we find out more recently is that it's probably only cam that is problematic in those terms. So we focused our research on cam morphology. You can imagine that if you have this bone shape and you put your hip in this end range position, that you could lead to hip pain. You could also imagine that it could be logical that in that same position, the bone would cause some camming or levering out or increased instability. Clinically, we think we see this, but of course it's challenging to quantify that type of instability. If we think about the way that we typically look at movement, we're using skin-based marker systems. And our co-authors have definitely shown that there's not a way to understand the underlying bone movement because of all the skin motion artifact that we have with that. So instead, the way we need to do that is by using dual fluoroscopy. With dual fluoroscopy, you have X-ray signals from emitters that get picked up by the cameras mounted behind the image intensifiers on the other side, and you have the person moving in the middle. So this gives you two 2D images similar to X-rays, except these are actually moving images. In order to really understand how the bones are moving, you have to then take the 3D CT reconstruction and align it with the fluoro images from each camera for each and every frame. This then gives you subject-specific motion and morphology combined. We did this for both level walking and inclined walking. The idea with inclined walking is that it can be symptomatic in this patient population, but also that it requires an increased degree of hip flexion, which may be problematic. Again, what we were interested in was how was the femoral head moving within the acetabulum. So we quantified this by calculating the distance between the bones, or the bone-to-bone distance. We selected our regions of interest within the acetabulum and within the femoral head, and then calculated the length of a normal vector between the acetabular surface and the nearest femoral surface. We also divided our acetabulum up into 6 regions, 60 degrees each. Within each region, we looked at the minimum bone-to-bone distance for each frame of the gait cycle, and at the changes in that minimum distance over the entire gait cycle. So this gave us our measure of instability. We then compared our FAI group to our control group for each region and each activity. What I have here is a control participant with that bone-to-bone distance measure displayed in the color scheme. Blue is farther away, red is closer between the two bones. We have early stance shown here, and now I'm going to switch it to late stance. And what you could probably see is there's really not much of a difference between those 2 points in the gait cycle. If, however, we switch to a patient with CAM FAIS and look at early stance to late stance, again, the red being closer bone-to-bone difference, we definitely see that there's a big change in how those look. This probably represents that the femoral head is moving within the acetabulum more throughout the gait cycle. When we evaluated this statistically, we found that individuals with CAM morphology did have larger changes in bone-to-bone distances than controls. This was significant in all regions except the anterior superior region. We also saw an effect of activity in the posterior superior region with greater changes during level walking, and in interaction in the inferior region where only the CAM group showed an increased distance changes during incline walking. So really, while we think of CAM morphology as disrupting joint mechanics at end range positions and contributing to pain, these pilot data indicate that hips with CAM FAIS do have larger changes in bone-to-bone distances, even during tasks such as walking. We believe that these data support the idea that CAM morphology may come with some level of instability, even at easier tasks that are age and range. So at present, we're expanding the study to increase the number of participants so that we can better understand the pathophysiology of FAIS. Thank you.
Thank you. So our second speaker in this set will be Amber Vocelle. She will be speaking on the effects of osteoarthritis on three-dimensional thumb motion and force production. Amber, you can take it away. Make sure you remember to unmute yourself.
Okay, sorry about that. Can you see the screen okay?
Yes, perfect.
Okay, great. So hi everyone, thank you for tuning in. Today I'm going to be talking about some of my dissertation work under Gail Schaefer and Dr. Tammy Bush, who is this year's Founders Day, our Founders Award winner. So osteoarthritis, or OA, commonly affects the thumb carpometacarpal joint, or CMC joint, located at the base of the thumb. We know that CMC-OA alters hand function. However, little research has investigated its effect on thumb-specific joint force generation and 3D complex thumb motions. As osteoarthritis progresses, the thumb can develop a zigzag deformity in which the first metacarpal subluxes and the proximal phalanx hyperextends. We hypothesize that CMC-OA causes asymmetrical thumb force production and alters motions during complex 3D movement tasks. During the study, we recruited a total of 58 right-handed participants, and we tested them in the right hand. These included 23 young healthy, 11 older healthy, and 24 individuals with doctor-diagnosed arthritis and symptoms in their CMC joint on the right side. All participants had both force and motion testing. For force testing, we used a multi-axis load cell and a custom-built apparatus to look at force production in 4 directions: radial abduction, so lifting the thumb back towards the participant; radial adduction, bringing the thumb down towards the index finger; palmar abduction, moving the thumb across the body towards the left; and palmar adduction, moving the thumb towards the right side of the body. Motion data was collected using reflective markers and a 7-camera motion capture system. We collected data during palmar abduction, adduction, radial abduction, adduction, as well as more complex motion tasks like repetitive circumduction, where the participant circumducted their thumb to enclose the largest area possible, and opposition. For both force and motion data, we would expect to see decreased abilities with age and osteoarthritic status. For the sake of time, I'm going to talk about female data only for our force data. So looking at our force data, we do in fact see a trend of decreased force production with increasing age and osteoarthritic status. This is significant. We're looking at radial adduction and palmar abduction directions. So our results illustrate that the female OA group had a significant reduction in adduction, but not abduction force production when compared to our young healthy participant group. Looking at motion data, we found that our young healthy participants had a larger range of motion than our older participant groups for palmar abduction, adduction range of motion. When looking at radial abduction, adduction, we found that all 3 participant groups had a similar range of motion. For circumduction, we found that our osteoarthritic participant groups had a significant reduction in the area enclosed compared to our young healthy participants. Similarly, looking at opposition, we found that the osteoarthritic group had a significantly larger distance between the tip of their thumb and the target location at the base of the 5th finger, suggesting that they were less able to reach the target location. So taken together, this suggests that the osteoarthritis participants had a significant reduction in their motion abilities during those 3D complex motion tasks, but not during the clinically tested planar motions, that is the radial and palmar abduction, adduction ranges of motion. In conclusion, osteoarthritis results in an asymmetrical reduction in force production, significantly affecting force during adduction, but not abduction directions. Osteoarthritis significantly decreased motion abilities during those 3D complex motion tasks prior to a significant loss of range of motion during the clinical palmar ranges or motions. So that is the radial and palmar abduction, adduction ranges of motion. So early 3D complex motion changes may have the potential to act as early identifiers of OA development and may aid in earlier diagnosis. In a clinical setting, we typically use grip strength and palmar motions, that is radial and palmar adduction ranges of motion, to look at hand and thumb function. However, our results suggest that valuable information can be gathered from multidirectional thumb forces and motions beyond what we can get from these clinically utilized measures. Both multidirectional thumb forces and motions have the potential to act as new therapeutic targets for interventions like surgery and therapy. Additionally, there may be a role for incorporation of the multidirectional thumb forces and motions in exercise therapy regimens. So I wanted to thank Dr. Bush, Dr. Schaefer, the members of our lab, and our participants. And I also am including a little bit of information about our research and our funding sources below in case you guys want some more information. Thank you.
Thank you, Amber. So our next 3 talks are going to be pre-recorded videos, but I'd like everybody to know that the speakers are here in order to kind of respond to questions and also respond to questions on Slack. So our next speaker is Bardiya Akhbari, who will be speaking on contact pattern of total wrist arthroplasty changes with the direction of motion in In-Vivo study.
Hello, my name is Bardiya Akhbari. In this talk, I'll discuss the in vivo articular contact pattern of a total wrist arthroplasty, or TWA. First, let's look at the wrist joint. The wrist is composed of 8 small carpal bones, each of which moves in different motion patterns to facilitate efficient and stable positioning of the hand. Since there isn't any muscular attachment to the carpal bones, their motion is driven by the ligamentous attachment and the compression forces from the distal structure or the metacarpal bones. When there is a severe injury to the carpal bones or there is a presence of osteoarthritis, these bones lose their shape and the cartilage between them degenerates. So we feel pain and we cannot move our wrist easily. One of the solutions of this pancarpal arthritis is total wrist arthroplasty, or TWA. TWA objective is to reduce the pain in patients and restore the function of the wrist. At the bottom left, you see a currently FDA-approved TWA design. In the surgery, surgeons remove the first row of carpal bones and cut half of the capitate and attach this system to it. You see carpal component, radial component, and polyethylene cap. The movement of polyethylene cap on the radial component mimics the wrist motion. Unfortunately, the problem with TWA designs is their high complication rate, for example, loosening of the implant, as you see on the right. To understand why there is such a high complication rate, we designed a study to see how the implant components articulate upon each other. Understanding the contact pattern can help us to detect possible impingement locations and improve the designs to avoid these problems. So to do so, we designed an in vivo biplanar video radiography study. We enrolled 6 patients who had the implant and captured the wrist motion while they moved the wrist in various postures. We also acquired the CT scan of the wrist because we needed the 3D models for further tracking them in the radiographic image. Using an open source application, Autoscoper, developed at Brown, we tracked the implants and created their 6 degrees of freedom of motion. Then we used distance field calculations for each of the components to evaluate the contact point and regions between the components. Our sensitivity threshold was 0.4 millimeter for detecting the center of contact. On the right, you can see this region of contact color-coded, and center of contact was calculated as the weighted average of this region. Now let's look at one of the anatomical tasks, flexion extension. On the right, you see the radial view of the wrist at its full extension. As you see, the implant has rolled forward volarly, and the center of contact has moved dorsal of the polyethylene cap and volar of the radial component. If you look at the X-ray, you see the potential for impingement and restricted extension range of motion. Flexion was an interesting posture too. Due to the design or the soft tissue restriction, flexion was not as large as extension, but we saw the center of contact is not rolling as dorsal as it could, which might stop the motion. Using mixed models, we evaluated these relationships in a mathematical sense. From extension to flexion, we observed the center of contact moved 10.8 millimeter from dorsal to volar on the polyethylene cap and moved 7.2 millimeter from volar to dorsal on the radial components. From radial to ulnar deviation, the center of contact moved 12.4 millimeter from radial to ulnar on the polyethylene cap and moved 5.6 millimeter from ulnar to radial on the radial components. Mixed models are powerful analytical tools because they can help us to create predictive model of the center of contact movement along with a 95% confidence interval. We use a 6-degree range of flexion extension in 20-degree steps and 40-degree radial ulnar deviation at 0, 10, 15, and 20 degree to predict the pattern. Based on an analysis of the in-vivo flexion extension motion, the TWA center of contact moves in opposite directions on the radial and carpal components, and it is most congruent on the radial side of the polyethylene cap. This behavior, which can be defined as forward rolling and backward sliding, rotation and translation are in opposite directions, might result in impingement and restriction of range of motion at certain wrist postures. Understanding the articulation and the type of articulation, for example, rolling or a sliding joint, can also help us in future computational modeling. Thank you so much for your attention.
Thank you. So our next talk will also be another video. It will be by Audrey Clark, who will be speaking on crista volume shows a relationship to sesamoid station. So our fabulous ASB technical support will be pulling that up.
And while we wait, I'll just MC that after this talk is over, about 12:35, we're going to be in the Slack channel, but we'll also be in the Qualysis Lounge to hang out and wander around and talk about the science. So please join us there and experience the live spatial chat if you haven't yet. It's pretty trippy.
Sesamoid. Hallux valgus, commonly known as a bunion, is a foot deformity commonly seen in the first TMT joint and is often accompanied by significant functional disability and foot pain. Sesamoid bones are two bones under the joint at the base of the big toes. As HV progresses, the first metatarsal drifts medially and the subsequent lateral drift of the sesamoids results in intersesamoidal crista erosion, which is the cause of a bunion. The crista is a ridge that separates the two sesamoid bones. As the sesamoids shift out of place, the crista separating the two sesamoids erodes as the contact of the medial sesamoid with the crista applies pressure with weight bearing. A standing CT machine and weight bearing pedal were used. The pedal system that was created fits inside of a CT machine in order to mimic that of a standing CT scan. Based on past research, we have determined that using the weight bearing pedal that we created gives very accurate results when compared to a standing CT. In our research, we analyzed the IM angle and the HV angle. Using scans that have been taken, we can derive lines drawn along the axes of the bones. Three-dimensional weight-bearing analysis with the CT is necessary to measure true pronation, since a 2D image like this one only gives us the angles. The orientation of the first metatarsal relative to the second metatarsal can be described by 3 sequential rotations as shown in the figure. These rotations are yaw, pitch, and roll, where roll is the pronation supination. The purpose of the current investigation is to examine the relationship of the volume of the crista to pronation, sesamoid station, and IM angle using 3-dimensional models. It is hypothesized that crista erosion is directly related to sesamoid position, IM angle, HV angle, and first metatarsal pronation and HV deformities. As shown in the pictures, you can see that in patients with HV, the sesamoids become displaced. As sesamoids are displaced, erosion of the crista occurs. 25 HV patients and 10 normal patients underwent CT imaging with weight-bearing or weight-bearing equivalent methods. Using the program Mimics, segmentation was performed to create 3D solid models. Pronation, IM angle, and HV angle were quantified from the 3D reconstructions. Crista cross-sections in each CT slice were demarcated by slice thickness, and the volume of the crista was computed for each patient. Sesamoid station was then determined using the 4-stage AOFAS scale. The sesamoid station was simplified into 2 categories, stages 0 and 1 and stages 2 and 3 for analysis. The mean crista volume of HV patients was 86 millimeters cubed and was 148 millimeters cubed in normal patients, with the t-test showing statistical significance. T-tests using simplified sesamoid station to compare crista volumes, IM angle, and HV angle of HV subjects only were all found to be statistically significant. However, the t-test using simplified sesamoid station to compare pronation was found to not be statistically significant. The regression of crista volume against the IM angle and pronation angle in HV subjects did not show statistical significance. The regression of crista volumes against the HV angle in HV subjects did show statistical significance. In HV, it has been hypothesized that the medial sesamoid erodes the crista, resulting in arthritis. This is often overlooked as a source of pain in these patients. Our study found that crista volume, HV angle, and IM angle were all related to a simplified taxonomy of sesamoid position. Pronation of the first metatarsal, however, was not correlated with the sesamoid position. Sesamoid station appears to be related to IM angle, but IM angle does not appear to be related to crista volume and needs further investigation. The HV deformity is characterized by the medial angulation of the first metatarsal, and the change in sesamoid station reflects that fact. That the IM angle would then not correlate to the crista volume may be a result of a large variance in a sample size of only 25. The relationship between the HV angle and crista volume does, however, agree with expectations because a large HV angle would malposition the sesamoids to cause crista erosion. The overall results emphasize the need to further analyze 3D data to relate the HV deformity and crista wear. Operative outcomes and early detection of HV offer possible implications for the importance of crista erosion and sesamoid malposition. This study is the first to demonstrate that medial sesamoid subluxation, as determined by sesamoid station, results in erosion of the crista. This supports the hypothesis that sesamoid subluxation, arthritis, and crista erosion are important components of the HV deformity.
Okay, reminder that you can still be typing questions into that chat window because our speakers are here to answer them. So our final talk of the section is going to be Junjun Zhao, who will be speaking on the development of injury risk functions for Lisfranc injury. And it's just going to take a moment to pull up that video as well.
Maybe we can get one question while we wait. So this question will be for Cara from Dr. Sheehan. And she's asking about what do you think the effects of changes in cartilage thickness because of the OA, how does that affect your results and what does that mean for the patients?
That's a great question. It's totally possible that some of the differences we're seeing are due to cartilage thickness differences. In these patients, they're younger patients who don't have frank OA, so I'm not sure that it's all about the cartilage thickness. But we are doing work to be able to look into that more deeply. Thank you.
Good morning. Thanks for coming. My name is Junjun Zhu. I'm from University of Virginia Center for Applied Biomechanics. The study I'm presenting to you today is the development of injury risk function for Lisfranc injury. Lisfranc injury is an injury to the midfoot in which one or more of the metatarsal bones are displaced from the tarsus. And it also causes disruptions of related ligaments. This frank injury is significantly higher in football players, yet are missed or misdiagnosed in 1 of every 5 patients. It can be associated with long-term disability and residual deformity, but currently no study has quantified the mechanism or tolerance of this frank injury. So we set up this series of biomechanical tests to address this problem. In Figure A, we try to replicate the injury with boundary conditions that are close to the real-world scenario. In Figure B and C, 10 related bones were affixed with reflective marker arrays for 3D kinematics capture. We also have strain gauges attached to the first and second metatarsal to capture the time of the injury. After test, the specimen was dissected by an orthopedic surgeon specialized in foot and ankle injury to determine the relevant injuries. In those specimens with Lisfranc frank injury, the most seen injuries occurred at the TMT joints, IC joints, and NC joints. Now, the corresponding forces, strains, and kinematics data at the time of injury was determined based on the time synchronized data. So we get some data points with injuries and some points with no injury. And these values were fitted using survival analysis with Weibull distribution. Y-axis here is the risk of injury from 0 to 1. X-axis is the predictor variable. The black line and the shaded area are the fitted injury risk function and 95% confidence interval. We chose 3 measurable variables for injury risk functions development. They are the resultant bending angle of the foot, the resultant force along the first metatarsal, and the compression percentage of the foot. Here on the left is a plot of injury risk function developed based on the resultant bending angle. So for example, we see here that the mean 50 percentile risk of injury is when the foot having a resultant bending angle of 23.9 degrees. And since the foot can bend medially or laterally, we also plot an injury risk heat map to accommodate the bending angles at the transverse plane and sagittal plane. So with a given foot posture, we can first calculate the bending angles at these 2 planes and then locate the corresponding point on the heat map to evaluate the Lisfranc injury risk. The blue region here means the risk of Lisfranc injury is relatively low, and the risk is high when the point locates in the red region. And with these injury risk functions, the results of the study will serve as baseline data for Lisfranc injury evaluation in sports-related scenarios, and can provide fundamental information for the development of countermeasure protections. Again, thank you for your time and attention.
Great, these are great talks. So I'll follow up with a question for Amber from Trey Crisco, asking you about if you measure the MCP hyperflexion, and if you did, how might this correlate with changes in the range of motion?
So that's a good question. So what I presented today was specifically looking at motion coming from the CMC joint alone. However, we did also collect data of the more distal joints. And we found that with our osteoarthritic participants using both goniometry, so basically a little protractor you put along the joint to look at ranges of motion, we found that there was increased extension in our osteoarthritic participants compared to both of our healthy groups. And then using the motion capture, we created a vector along the metacarpal and along the proximal phalanx or phalange. And we looked at the angle between them. So neutral was going to have your angle being at 0. And then we could look at flexion versus extension by looking at the range of motion, basically using a variant of the dot product.
Thanks. And a follow-up from Jen Nichols about how does this experiment and how you measured the motion correlate with the functional demands that these patients need in their day-to-day lives?
So that's a good question. So I think, obviously, I don't expect to see a lot of people doing repetitive circumduction in everyday life, but I do expect that it gave us. It gave us two different pieces of information. First would be that it tells us a little bit more about overall function than we can get from looking at those just single planar motions. Additionally, when you think about how you would go to reach for something, you don't necessarily reach in a specific plane, right? You don't necessarily reach just across or just up, so just in palmar or radial directions. Oftentimes, you might use a combined motion. So we're kind of trying to get at that a little bit too, and kind of see what other things could be interesting to look at in the future, if that makes sense as well. And additionally, I think that this shows that there are, maybe the 3D motions might be more sensitive because we are looking at more complex tasks than you can look at with just those simple planar motions.
Thanks. So the next question will be for Bardiya. And these questions are really focused on the idea of using this model to understand the loads that are being transferred through the arthroplasty into the underlying bone. And Jen Nichols asks a question about what are the types of motion patterns that you think are most concerning when trying to replicate the natural motion of the wrist with an arthroplasty? And can you take yourself off mute if you're muted right now? We can't hear you. No problem. We'll move on to questions for who's our next talk for Audrey, and this is from Tammy Bush, asking about what are the interventions used to treat this, and how can you believe that your findings can help or change what is currently being done, and or when it is being done from a clinical standpoint?
So currently, people normally get surgery when they're older in age and experiencing pain, but with our recent research, we think that we can see when someone's about to get a bunion or is forming a bunion. So we're hoping that in the future they can make perform a non-invasive surgery to prevent the bunion from ever forming in the first place, because if you know, bunion surgeries take about 2 months, no applied pressure to the foot to heal. So it make it a lot more convenient.
Great. And a follow-up methodological question about, can you explain if it was imaging, or how were the images taken during a standing configuration or during some pedal push loading activity?
So we had patients from 2 hospitals. One was HSS, which they have a standing CT machine, but those machines are very expensive. So we actually created a foot pedal that mimics that of a standing CT machine that fits inside of a normal CT machine. So based on past research, that is almost the same as a standing machine. So we had a combination of both patients using the pedal and an actual standing machine.
Great, thank you. And we have time for a couple quick questions for Jun, asking about simulating these complex injuries in cadavers can be challenging. This is from Jen Nichols. What do you think is the biggest limitation of using a cadaveric model of the injury?
Right, thanks for the question. I think the biggest limitation is the loading conditions. And these injury risk function injuries usually happen in sports scenarios or the car accident when your foot is on the pedal. So these injuries happen in a really short period of time. In our cadaveric testing, the loading speed is 1 millimeter per second. So it's relatively slow. But in terms of mechanism or the tolerances, I think these are fine. But if we are having a faster loading speed, that might have a different results from these specimens.
Great. And in terms of application, what does this mean about designing shoes that might limit the range of motion and prevent these injuries in these high performance athletes? And how do you protect these very delicate feet?
Yes, absolutely. So one application is for the shoe manufacturer to make the sole stiffer, or for the rehabilitation program development. Because if patient will get injured and we have reconstruction or rehab, we want to minimize the range of motion of the midfoot to avoid the foot being injured again.
Thank you.
Thank you.
And I'm happy with that. I can speak on behalf of Jess, who's muted right now, that this was a great talk, lots of awesome science, and we'd love to continue these conversations both in the Slack and in the spatial chat to continue these conversations to get a little more information from you guys about this great science. So thanks so much.
Thanks to all our speakers.